Basically just said to people, what's good about our service, what's not good about our service, what do you think we're lacking in? And we got some really prominent stories, and from that we were able to say to people, this is why we need to change. Yeah. And when you talk about the human factor, I think that's even more important. If you always associate it with yourself, so if this was your granny, if this was your child, if this was your husband, wife, brother, sister, do you think the service they're getting suits purpose? And, shamefully it didn't. And it still doesn't completely, but it's better than it was. There's different ways of doing a consultation. You can gather lots of information and you can put it out as this is what we think, what do you think? Or you can go out there and ask them and then from that collate it. So we did a combination of the two really. So we said to them, this is what we think we need, what do you think? And that included everything from the time that they started to the time that the shift finished, if we needed to have alternative shifts, so like an 8 to 4, a 9 to 5, a 10 to 6. We asked them about break times, we asked them about lunch times, we asked them, we basically put out some suggestions but then said, right, you come back with some. And actually, the people on the shop floor are the ones that understand better than people that, none of us sit in offices, but they do understand their service requirements each day. And they did come up with alternative suggestions which worked really well. People were saying, well, what do you need an OT for at the weekend? And well, I never trained to work Saturday and Sunday. That's not what. Actually, in reality, when they started doing it, they said, this is brilliant. We don't get managers bothering us. We don't get emails. We don't get, we can get hands-on patients all day. Of the staff afterwards actually said, we feel better at work now because we feel like we're working in a safe zone as opposed to potentially making unsafe decisions, which clinically is quite hard and traumatic to do. So, when we first going back to when we employed 3 OTs who worked weekends, one of them was doing a master's, and so that freed her up to attend university during the week. Another one had childcare issues, which meant her husband could look after the children at the weekend, so she worked 4 days and 2 of them childcare was sorted. And then the other one, her husband worked flexibly because he ran his own business. So actually they got more time together by doing it that way. So historically we've had jobs that have been advertised that are for nurses, and we've challenged, why does it have to be a nurse? Why can't it be an AHP? We've got a really great skill set as well, but people often are sort of blinkered as to, well, that has to be a nurse because it's always been a nurse, or that has to be a doctor because it's always been a doctor. I think because there's been a push on developing different posts. So, for example, we now in paediatrics we run clinics where they get seen by a physiotherapist rather than a doctor. So, and that's happened in musculoskeletal actually for a long time, but just thinking about paediatrics specifically this year, it was actually paediatrics musculoskeletal, so children with orthopaedic problems, so spines, knees, hips. We recognise that actually sometimes people are referred for surgery when actually they don't need surgery, they need conservative treatment, and actually if you go down that path you save everyone a lot of pain because you don't want to be cutting someone open if you don't need to. So actually by having a physiotherapist in clinic who says, right, well, I'm going to do XYZ with you, they then come back for their treatment at a different time, but they get assessed in that clinic setting. Then if there's a problem they will then refer them back in, or sometimes it's immediately obvious that actually it needs to be surgery. But once you've got people with those skills, so there's sort of extended scope, clinical specialist type roles, then actually that can relieve the pressure from the consultants list, and they can see the people that you absolutely know have to be dealt with in that respect. So there are lots more opportunities for therapists now than there were before, and like I said, going into, so we have we've got somebody up on MOP who is a therapist by background.
Sorry, MOP is medicine for older people.
Sorry, I keep forgetting, you get used to it, don't you? So yeah, in medicine for older people, one of the case managers is actually a therapist, so she has extended her role. She works as a case manager, but actually that was opened up to AHPs, so it could be a nurse, could be an OT, could be a physio. So there's a lot more opportunity for therapists now, which is again one of the reasons why we need more, because that hasn't been catered for when they've talked about how many people you need to do your OT or physio role, actually, what about all the other roles that you could now do as well? We work with two equipment providers, one for Hampshire and one for City, and they don't work 7 days. So from an OT point of view, if I want to get a bed for a patient for Hampshire from Friday to Monday, absolutely nothing. For Millbrook, there's a possibility I could get it on a Saturday morning. So if you imagine every time we have a 4-day bank holiday, like over Easter, there's absolutely nothing we can do. So if we don't get them out before then, they're stuck here if it's essential for discharge. So until those services are commissioned 7 days, that's always going to be a problem. If you're dying of cancer on a Friday and you happen to live in Hampshire, there's absolutely no way we're going to get you a bed before Monday, and you might have missed your window of opportunity to get home.